Heart sounds may seem simple, but many students realize during exams or clinical rounds that they are not fully confident about what they are actually hearing. They may remember the name of heart sounds, but not the mechanism or timing behind them. The goal of this video is straightforward. By the end of this lecture, you will understand where to listen, why heart sounds are produced, and how to correctly identify S1 through S4 using logic rather than memorization. First, let's talk about where to place your stethoscope. You have probably seen standard diagrams showing the aortic, pulmonic, tricuspid, and mitral area. These diagrams are helpful, but many students forget why these areas are arranged the way they are. The key lies in the direction of the great vessel. The aorta travels towards the right side of the chest, while the pulmonary artery crosses toward the left. Because of this anatomy, the aortic and pulmonary area are located close together in the upper chest, a region we call the base of the heart, located at the second intercostal space. Right side is aortic and left side is pulmonic areas. Between the aortic and pulmonary areas, there is an important listening point called Elb's point, located at the left third intercostal space. At Elb's point, both A2 and P2 can often be heard clearly, which makes it especially useful for evaluating the second heart sound. Clinically, Elb's point is also a very good place to start auscultation. By placing the stethoscope first, you can quickly detect whether any abnormal heart murmur is present before moving on to more specific areas. Below the base, you listen along the left lower sternal border for the tricuspid area. It's at the around 4th intercostal space. Further down, at the 5th intercostal space, along the mid-clavicular line, you find the mitral area, also known as apex. One practical point is worth remembering. S1 is best heard at the apex, while S2 is louder at the base of the heart. Keeping this in mind already makes auscultation much easier. Now let's move on to how heart sounds are generated. Think about a simple question. When does a door make a sound? When it opens or when it closes? In most cases, the sound is louder when the door closes. Heart valves behave in the same way. Heart sounds are mainly produced when valves close, not when they open. S1 is produced by closure of mitral and tricuspid. S2 is produced by closure of the aortic and pulmonic valves at the end of the systole. With that basic rule in mind, we can now understand extra heart sounds. Let's focus on what happens in the left ventricle during systole and diastole phase. After closure of the mitral valve, we can hear S1 at this point, and after that, aortic valve starts opening and then close. Of course, we can hear S2 at this point, and mitral valve open and repeat. Under normal condition, blood flows smoothly from the arterial into the left ventricle and is then ejected into aorta. Extra sounds appear when ventricular filling becomes abnormal. The third heart sound, S3, occurs in early diastole, just after S2. It is caused by large inflow of blood into the ventricle. For example, when 10 plus 10 into the ventricle, but the capacity only 15, leading to vibration of the ventricular wall. It is the third heart sound. S3 can be a normal finding in children, young adults, and pregnant women. In older adults, however, it often suggests volume overload and heart failure. The fourth heart sound, S4, occurs in late diastole, immediately before S1. It is produced when atrial contraction forces blood into a stiff, non-compliant ventricle, again causing vibration of the ventricular wall. For example, 10 comes in, but the capacity is only 7, but atrial contraction forces 3 blood into ventricle. Because S4 depends on atrial contraction, it disappears in atrial fibrillation. Now let's clarify the timing, because this is where confusion often occurs. Heart sounds are heard in the order S1, S2, S3, and S4 if all are present. S3 occurs after S2 during early diastole. If S4 is present, it follows later diastole. S4 is always immediately followed by S1 of the next cardiac cycle. Understanding this sequence allows you to identify heart sounds accurately without guessing. Before we move on to split of the second heart sounds, let's connect heart sounds with ECG. This relationship is frequently tested in the exams, and it is also extremely useful for understanding cardiac murmurs in clinical practice. In many ways, this timing is the core of cardiology. Now let's look at ECG. Here you see the PF, the QRS, complex, and the T wave. Let's review what is actually happening in the heart at each point. First, the atrium contracts. This corresponds to the P wave. Next, the ventricle depolarizes and begin contract. This corresponds to the QRS complex. After that, the ventricle repolarizes and relaxes. This corresponds to the T wave. This mental image is very important. Ventricular systole begins just after the onset of the QRS complex around the R wave because electrical depolarization is immediately followed by mechanical contraction. Ventricular diastole begins near the end of the T wave or just after it, when ventricular relaxation starts. With this in mind, we can now place the normal heart sounds on the ECG. S1 marks the beginning of systole. It occurs around the R wave, just after the onset of the QRS complex, when the mitral and tricuspid valves close at the start of isovolumetric contraction. S2 marks the end of the systole and the beginning of diastole. It occurs near the end of the T wave or immediately after it when the aortic and pulmonic valves close. Once you understand this timing, the position of S3 and S4 become much easier to understand. Both S3 and S4 occur during diastole. S3 occur in early diastole during rapid ventricular filling. S4 occurs in late diastole during atrial contraction. If you can visualize this entire sequence on the ECG, you no longer need to memorize where S1 through S4 occur. You can simply reason it out. I'll summarize a little bit here. QRS is start position of systole. T wave end is that of diastole. Diastole starts after depolarization, and S1 occurs in systole phase. S2 occurs end of the T wave, the start of diastole. Now let's move on splitting of the second heart sound. S2 consists of two components: closure of the aortic valve and closure of the pulmonic valve. Aortic component is relatively constant, while pulmonic component varies with respiration. Basically, A2 occurs earlier than P2, but during inspiration, venous return to the right heart increases. This prolongs right ventricular ejection and delays pulmonary valve closure, resulting in physiologic splitting S2. During expiration, venous return decreases, and the split becomes narrower. If you understand the relationship between respiration and venous return, why many murmurs change with breathing, posture, and volume status. Before memorizing individual murmurs, make sure you are solid on the basic mechanisms. They may look simple, but try reproducing them from memory on paper. You will quickly realize that true understanding is harder than memorization, but far more useful in both exams and clinical practice. Stay calm and act fast. See you in the next video.